So today we'll be talking about the association between childhood poverty trajectories and the association with weight status and also nutrition from the ELDEQ sample. I'd like to first acknowledge the ELDEQ team, made of many of the researchers presenting today. So in adults, we know that low SES is associated with poor health, and it's been found that actually their childhood SES status is actually a stronger predictor for their adult health than their adult SES. However, the association among children and youth is less clear. In particular, a systematic review published a few years ago found that in general, only about half of the cross-sectional studies looking at the association between poverty or between SES and health in children found any sort of association. And in particular, they found that this association was about least consistent when you use household income as your SES measure. Unfortunately, there's limited longitudinal data, and we suspect that since household income might be more likely to change over time compared to like parental education or parental occupation, that perhaps association between household income and health will be best assessed through longitudinal studies. And so the main objective of our study was to improve our understanding of how poverty may affect the risk for overweight and obesity during childhood and also nutrition behaviors. And specifically, we wanted to assess whether there was a particular age at which the association may appear, whether the association may persist or change over time as the children aged. And because the majority of studies have been done cross-sectionally, we wanted to also assess to see how longitudinal estimates might vary from something more considered to be cross-sectional. Once again, we are using the ELDEQ sample, which, just to remind you briefly that this is a birth cohort, representative sample of singleton births born in Quebec in 1998. The data collection was conducted annually in the participant's home with the person that knew the child the best, which was most commonly the mother. And Louise presented the trajectories from birth to age 10, and I just want to point out that our trajectories are very similar when we looked at birth to any other age. So in particular, we looked at birth to age 6, birth to age 8, birth to age 10, and birth to age 12. And we found this pattern to be consistent in all four of the ages, where the majority of the participants were in the low to no risk for poverty, noted here on the red line. And then we had about 10% of our sample that were consistently in poverty, or chronic poor children. And then we had about 20% of our sample either having an increasing risk for poverty over time or a decreasing risk for poverty over time. So for our first outcome of interest, which was the risk of being overweight or obese, we used the study staff measured height and weight, which was measured at age 6, 8, 10, and 12 in the children. Unfortunately, before the age of 6, the parents had reported the child's height and weight, and so we did not look at the association with obesity at that age. And we then compared their height and weight to the CDC recommended reference curves for their age and sex stratified peers so that we could have a better sense of how does this child's weight compared to a child of their similar age and sex. Our longitudinal analyses use the trajectories that Louise previously mentioned, and to discuss potentially more cross-sectional sort of analyses, we defined poverty based on the more commonly used measures in cross-sectional studies, such as ever exposure to poverty or if the household was currently poor. Our main outcome of interest was whether the child would be identified as being overweight or obese at 4 specific ages, at age 6, 8, 10, and 12. And we adjusted for several covariates, including sex, birth weight, parental occupation, and immigration status of the mother. I just want to point out that I'm using actually the complete cases for this analysis because this is what has been published. But when we did go back and look at the multiple mutation, our results are very similar. So I just want to point out a couple of things. When the children were aged 6 and 8, their BMI was right around the average, around the 50th percentile compared to their same sex and same aged peers. And then by the time they were age 10, their BMI percentile went up to about the 60th percentile. This might indicate potentially the onset of puberty in the children. For our trajectory groupings, you see here that when we do the trajectories from birth to our 4 specific ages, that our distribution of the trajectories are very similar across the 4 ages, with approximately 75% being in the low or no risk to poverty, and about 25 to 30% of the children being fairly evenly distributed in our 3 other higher risk groups, either having chronic poverty, increasing risk for poverty, or decreasing risk. And for our 2 cross-sectional measurements down below at item 2 and 3, we found that on average about 10% of our sample was currently living in poverty at any of the 4 specific ages of interest, and that about a third of them had ever been exposed to poverty in the past. We thought that so when we think about the highest risk groups of poverty, we can think about either the chronic poor children from the trajectories, the children currently living in poverty, as well as the children that were previously exposed to poverty. And in particular, we were concerned that perhaps our chronic poor children were essentially the same children as those found in currently poor households because their distributions were very similar. And so we wanted to assess was the proportion of time that the children had been living in poverty based on these different sort of conceptualizations. And we found that for the children that had been ever exposed to poverty, on average, they lived about 40 to 50% of their childhood up until that age in poverty. Noted here in the green. For children that were currently living in a poor household, they on average lived about 60% of their childhood in poverty. But that based on our trajectories, we found that the chronic poor children were living about 3/4 to 80% of their time in poverty. And this suggested to us a couple of things, that the different ways you can conceptualize poverty really were distinctive from one another, and that our trajectories were really finding potentially the highest subset of the subset of children that were potentially at highest risk for poverty because they had spent the longest proportion of their time in poverty. And we found that in comparison to children that were living in households that were never poor, those children that were living in chronic poor households were about 2 times as likely to be overweight or obese when they were age 8, and that this association was fairly consistent when they were age 10 and 12 as well. We found some evidence for an increased risk for obesity depending on if the child had been previously exposed based on decreasing risk for poverty on our trajectories. And then we also saw that by age 10, the cross-sectional measurements of either previous exposure or current exposure to poverty was also associated with elevated risk for overweight and obesity. But we thought it was interesting that those more cross-sectional measurements were generally attenuated compared to our trajectories. And this suggested to us that perhaps based on the way the data is collected, that cross-sectional measurements really would underestimate the associations. So for our second outcome of interest, we look at the nutritional behaviors of the children, and this was based on the parental report of their child's eating behaviors in the past week. And the categories of interest for us were dairy products, including milk, cheese, and dairy desserts, fruits and fruit drinks, vegetables, snacks and baked goods, as well as sodas. And what we wanted to do was we wanted to assess the likelihood that the children met Canada's food guide recommendations for these nutritional behaviors at their specific ages. And so Canada's food guide recommends that for children between the ages of 4 and 8, they should consume at least 2 servings of dairy and at least 5 servings of fruits and vegetables a day. And that when the children are between the ages of 9 and 13, that they should increase to at least 3 servings of dairy and at least 6 servings of fruits and vegetables a day. There are no specific guidelines for consumption of soda and snacks, but we conservatively chose less than 2 portions of snacks a day and less than 1 soda a day. But when we did try other sort of variations of these, we found really no difference in our results. Once again, we'll be using the trajectories of poverty for our longitudinal analysis, and for the sake of time, I won't talk about the cross-sectional measurements, but they were very consistent with what we found in the weight status. And our outcome of interest is now the likelihood that the child meets Canada's food guide recommendations for dairy, fruits, vegetables, baked goods, as well as sodas, after we adjusted for several covariates. And I just want to point out a couple differences between this analysis and our previous analysis. This one we did use multiple imputation, and because the nutritional behaviors was obtained only at age 6, 7, and so on, we could not assess the nutritional behaviors at age 8. So the weight status looked at ages 6, 8, 10, and 12, and now we're looking at age 6, 7, 10, and 12. So for these children, about 3/4 of them met the Canada's food guide recommendations for dairy products when they were age 6 and 7. But then when they were age 10 and 12, this dropped down to about half of the sample. And this may be due to the fact that when the children are at least 10 years of age, their recommendation is now at least 3 servings of dairy rather than 2 servings. About a third of the sample met the food guide recommendations for fruits and vegetables at all of the 4 time points. And the vast majority of the children consumed less than 2 servings of snacks and 1 soda a day. So consistent with what we found with the weight status, compared to the children that were living, that had either low or no exposure to poverty, children that were in a chronically poor household were about 40 to 50% less likely to meet the food guide recommendations for dairy products. And this is fairly consistent across the ages. These children that were in chronic poor households were about also 40 to 50% less likely to meet the food guide recommendations for fruits and vegetables as well. We found no association with snack goods, but we did find that the children that were in chronic poor households were significantly less likely to have less than a soda. So essentially, they were more likely to have more than one soda a day. We did find some evidence again for other sort of exposures to poverty. So if you were at an increasing risk for poverty, you were also less likely to meet the food guide recommendations for either dairy or fruits and vegetables. So one of the main strengths of the study is that we were really able to assess the chronic exposure to poverty. And we found a couple of things. We saw that our chronic exposure was really a distinctive measure from what would be conceptualized as cross-sectional measurements of either ever exposure to poverty or current exposure to poverty. However, there are several limitations to our study. We do have mainly parentally reported data. So the parents reported their income as well as reporting the nutritional behaviors of their children. And there are also probably a number of covariates that would like to assess in future studies, including the role of stress and cortisol, as well as other variables. Nevertheless, we found that chronic exposure to poverty was associated with a significantly elevated risk for overweight and obesity by the time the children are age 8. And that even before the manifestation of obesity, we saw that they were significantly less likely to meet certain nutritional behaviors as well, starting from at least the age of 6. And it would be of interest to see if this association continues to either strengthen or if it's fairly consistent as the children age in future studies. Okay, thank you.